Morning, everyone. So I'm just going to talk to you about what steps we can take to achieve a smoke-free NUH. So we've got some key things in place. We've got a smoke-free site policy, although often it doesn't look like it if you take a walk around the campus and have a look at the main entrance and so on. But there are things that we're doing in the background to kind of work towards that, having a full smoke-free site. We've got things like a key 30-second intervention that's evidence-based, and it can double the chances of your patients accessing support to quit. And once they've accessed that, it actually triples their chances of success. So that's something I'm going to talk about in this presentation. Also, I'll just cover a little bit of background about why smoking cessation is still important, and then having those effective conversations with your patients. And then also I'll talk about stopping smoking prior to surgery and some issues that there might be around that. So if we think about smokers and patients that you interact with day to day, what percentage of smokers do you think actually want to quit if you think about consultations that you have and the responses that you've had? Does anybody want to kind of shout out an estimate of what percentage do you think actually want to quit?
32%.
32%. Anybody else? Half. Okay. So it's actually 70%. So we often kind of underestimate that. You might get negative responses when you talk to patients about stopping smoking, but actually 70% do want to quit. But the issue is that they don't know how. They don't know how to get support, how to go about it. And they think they won't be able to do it, which is why we get that kind of negative response. But it's positive, so we've got that captive audience there. We've got 70% of patients that will actually want to quit. So what our role is really is to make sure they know how to go about it, how to get support to make that attempt to quit. So it's just a little bit of background, which you probably already know. So smoking is still one of the biggest causes of preventable ill health and death. So in England, there's still over 489,000 hospital admissions that can be linked to smoking. There's over 77,000 deaths. And at the moment, about 14.4% of adults in England are classed as smokers. So that's around about 6 million people. So if we have a look at that locally, so unfortunately in Nottingham City, the prevalence is quite a bit higher than the England average. So it's at about 20.6%, whereas in the county, it's lower, so it's similar to the England average. So in the city, obviously we've got higher levels of deprivation, and also there's been a lot of cutbacks with stop smoking services in the community. They've not been consistent, so that's also had an impact. And the prevalence has kind of, although over the last 10 years it has come down in Nottingham as well, for the last few years it has remained stagnant. Whereas in the county, they've had a more stable stop smoking service. They've not had as many cutbacks. There's kind of more affluent areas in the county as well that bring that prevalence down. Although there are some pockets, for example, in Mansfield, where the prevalence is actually as high as Nottingham City. So although it's fallen, so there's about 1 million less smokers now than there were 10 years ago. So we've still got those 6 million to go. So we've still got lots of work to do. So what can we do to make a difference? So all the evidence shows that advice from health professionals is one of the most important triggers for a quit attempt. So when smokers are kind of admitted to hospital or they've got kind of medical appointments, the health is obviously going to be at the forefront of their mind. And they might actually think that the condition is to do with their smoking, so it's in their mind. So that can be an important trigger if the health professional raises the topic or has that conversation with the patient. Also, we've got evidence that shows, compared with no advice to smokers, the likelihood of quitting is 68% higher if stop smoking medication is offered. So, for example, if a smoker comes in to an outpatient appointment, and they've been given some patches to use, they'll be 68% more likely to try and quit. And if they're offered support alongside that, so they're offered some patches and then they're given a referral or booked in with their stop smoking advisor, then they'll be 217% more likely to make that quit attempt. So traditionally, the focus has been on informing smokers of the harms caused by smoking. So kind of, for example, listing all the ailments they could get from carrying on smoking, showing them horrible pictures of blackened lungs and so on. But actually, it's the offer of support that's more effective than kind of talking about all the illnesses and things that they can get, because most smokers are actually aware of that now. So as I mentioned before, it's actually that they don't know how to get support. So the offer of the support is the most effective thing to do. So thinking about kind of smoking cessation and support, you might have seen this term used around at the moment, tobacco dependence. So this is kind of a new way of looking at smoking. So in the past, we've used kind of more negative terminology around stopping smoking. So using words such as, you know, you must have willpower, you need to be motivated, it's your fault if you fail, it's a lifestyle choice. So that kind of all points towards it being someone else's role to help. But now we're looking at it more as a kind of disease, it's chronic disease management, really. 70% of people that have quit, unfortunately, will go back to smoking within a year. So it is actually a long-term relapsing condition. We've got lots of treatments that work. No matter which kind of area that the patients come into, so whether it's respiratory, maternity, they'll all benefit from stopping smoking. So it should be every clinician's role, really, to treat tobacco addiction. So if we look at stopping smoking prior to surgery, so obviously compared with non-smokers, smokers are going to likely have longer hospital stays, higher risk of readmission, and more likely to be admitted to intensive care. And then stopping is obviously going to mitigate these risks, and longer periods of abstinence is going to have more benefits. But although the data and evidence we have at the moment doesn't give any clear advice on an optimal period of pre-operative smoking cessation, but it's always kind of beneficial to do that. I think there have been some kind of presumed risks of quitting smoking close to surgery. So sometimes we hear of patients that have had their kind of appointment and surgery is imminent. They've been told kind of not to quit smoking because it's too close to their surgery. So the reasons for this are there have been some studies that have shown risks of quitting smoking close to surgery. For example, stopping smoking could lead to a decrease in coughing, and then increased sputum, which can cause complications. Some people have been told stopping smoking increases stress. So if the patient's obviously already anxious and stressed about imminent surgery, so stopping that could make it worse. Also, the use of nicotine replacement therapy to stop smoking close to surgery has been quite kind of controversial as well, because nicotine is seen as having a detrimental effect on healing complications. So there have been some kind of systematic reviews of these studies, and actually there have been no significant effects found. And also some of these studies have had quite a few limitations as well. So for example, patients or participants have self-reported their tobacco usage and their nicotine replacement therapy methods. So it's not been possible to kind of eliminate the possibility of concurrent usage of NRT and tobacco. So that's actually not uncommon. So sometimes we do see people coming in, they've tried to use patches, but they've actually carried on smoking with it as well. Also, the doses of nicotine that you get from nicotine replacement therapy, so from things like patches or inhalators, is a lot lower than the dose that you get from smoking. When you smoke, you light the cigarette, inhale the nicotine, and it sends the signal to your brain to release the dopamine within about 5 to 7 seconds. Whereas if you put a patch on, it's going to take a good 20 minutes before it kind of kicks in and eases your withdrawal symptoms. So it's a lot lower. Also, the latest NICE guidance we've got, which is called NG209, so that's all about treating tobacco dependence in secondary care. So in there, the advice is really only to cease nicotine replacement therapy 24 hours before, and it's just in these conditions really, so before microvascular reconstructive surgery or surgery using vasopressin injections. And even in that guidance, they say that it's worth noting that the use of nicotine patches is a lot safer than returning to smoking. So even if a patient has been told, not to smoke 24 hours before their surgery, that can be really difficult. And it is likely, if they're not using any nicotine replacement therapy, that they will have a sneaky cigarette before their surgery. So it's safer. It's kind of harm reduction really, if they've got a backup that they can use before surgery. So if we talk about the actual quitting process, so we've got 3 essentials really that we need for a successful quit. So obviously the patient's got to want to stop. Then we need good quality support in place and evidence-based treatment, so things like nicotine replacement therapy. And using a stop smoking service alongside that is 3 times as effective as making an unassisted attempt to quit. So the conversation that we should be having with patients, so saying something along the lines of, you really need to stop smoking now, will literally have the same effect as saying nothing at all. So that's going to come across as quite negative. It could be seen as nagging, and that can encourage conflict and denial in the patient as well. So we've got an evidence-based way of having this conversation, which is known as very brief advice. So it's based on the 3 A's model. That's ask, advise, and act. So asking is basically just establishing whether or not they smoke. So do you smoke, or how's it going with the smoking? Then the advice, so that's simply just giving them the evidence-based advice. Did you know the best way to stop is to use a combination of stop smoking support and medication? And then the act part is the referral. So for inpatients, they're automatically referred if they're flagged up as a smoker. So there's a mandatory smoking assessment that the admitting nurse does. So they would be advised to tell the patient a stop smoking advisor will be in touch, and when you are ready, they can support you with quitting. For outpatients, we have a referral system on Medway. So you raise an order like you would, for example, to order a blood test. So that's the way to do it for outpatients. So the benefits of doing it that way, it should be brief enough to use routinely. So in theory, it should just take 30 seconds to do that ask, advise, and act. But often in reality, you might get a chatty patient. So once you've raised that, they might want to go into their whole smoking history with you, but you're not doing the stop smoking consultation. It's just a brief signposting. So we advise people to say something along the lines of, as this is such an important conversation, I think it's best if you save it for the stop smoking advisor who'll be able to give you the attention this deserves. So the stop smoking advisors have a full half an hour within which they can have the full conversation with the patient. So it's coming across as more positive and non-confrontational. You're not telling anybody what to do. You're simply just establishing whether or not they're a smoker and giving them the evidence-based advice. So then it's up to them if they want to take on that support. So this is a more kind of engaging and positive way of talking to smokers about quitting. Have a brief look at nicotine replacement therapy. So for inpatients, we encourage staff. So it's important to encourage whether or not the patient intends to remain quit when they leave hospital. When patients are asked if they want to use NRT, there's only about 25% that will say, yes, we'd like to use it. So usually they don't want to. So they often underestimate the physical effects of the withdrawal. They might even attribute it to what they've come into hospital with in the first place and not realise that, you know, if they use some NRT, they will feel a lot better. The nurses are to reiterate that smoking is not allowed on the grounds, you know, so it is better for them to use some NRT to stay comfortable whilst they're in hospital. The staff are not to facilitate them going out for a cigarette. So we do allow vaping on the ground. So I'll talk a little bit about vaping as well. We have some PGDs in place, inpatients and outpatients. So that means that nurses, midwives and pharmacists can also issue NRT, which makes that process quicker, because we're finding it was taking a long time for patients to get access to their NRT. So by that time they're suffering with their withdrawal symptoms. So it's taking time for the nicotine to get into their system to alleviate that. So we've got, I'll just quickly run through this because there's more for kind of the nurses. So we've got different strengths of patches and an inhalator on the PGD, or available on ward stock as well. And patients are also, if they want to and they're doing well and they've remained quit, they can get 2 weeks on TTO as well. And we have this decision aid for staff as well, to kind of so they can gauge what strength of nicotine replacement therapy to give the patient. So we usually look at how soon they smoke after waking up. So usually if it's within the first half an hour, we know that they're quite dependent on nicotine, so we'd go for a higher strength patch. So even if they're just smoking 5-10 a day, if they're smoking within the first hour of waking up, it's better to go with a higher strength patch. If it's over an hour until their first cigarette on waking, we'd go for the medium strength, but it can be a bit of trial and error with that as well. And we recommend combination therapy, so that's using a combination of a patch and something alongside it, for example, the inhalator. So the patch gives them a steady supply of nicotine throughout the day. And then if they're kind of craving in between, if they're feeling stressed or after meals, kind of the habitual cigarettes, they can use the inhalator to kind of alleviate that. And then this is just advice to patients that we give, just to reiterate to them, you know, that they'll be 3 times more likely to quit doing it this way. And also to explain to them that NRT delivers clean nicotine. So nicotine is actually the least harmful part of the cigarette. It's obviously the bit you get addicted to, but it's all the other 4,000 chemicals in the tobacco smoke that kind of cause the problems. So it's safe to use, and also smokers are used to really high doses of nicotine, so it's really unlikely that they're going to receive higher doses of nicotine through NRT than they're used to. So if we talk about vaping now, so someone that's been vaping only, so not smoking at all, just purely vaping for 6 weeks or more, is classed as a non-smoker or an ex-smoker. So there's been a few evidence reviews into vaping, and one recently as well, at the end of last year, which still shows that vaping is 95% less harmful than smoking. And there's also no evidence of harm from the kind of clouds of vape that you see to bystanders, which is why we allow that on site. And we also shouldn't discourage patients from vaping. Sometimes we find that they've done really well with vaping, they've quit smoking completely, and then they've come to a consultation and been told not to vape, and then they've relapsed back to smoking. So it's a lot safer for them to continue vaping. So the evidence shows they are effective aids to stopping smoking. In England, they are actually well regulated in terms of quality and safety. And they can be recommended. So in the latest NICE guidance, and I don't know if you've heard about, there was a review into kind of tobacco control and the Smoke-Free 2030, which was the government's ambition to reduce smoking prevalence to 5% or less by 2030. There was a review on that's called the Khan Review. So that also recommended vapes as an option to help people stop smoking. Yeah, and it's preferable to kind of use that as part of a behavioural support programme. So if they've got a vape and they're getting support from a local stop smoking service or a stop smoking advisor, that's the most effective way of doing that. So referral and follow-up. So once you've referred the patient or you've done your 30-second brief advice, and on Medway you've referred the patient, so you can literally raise that referral by searching for smoking under orders. You don't have to put any details through. You just click to place the order, and it's automatically emailed to the patient's local stop smoking service. So they then contact the patient within 1 or 2 days. And then if they wish to continue quitting, they'll have a 12-week kind of support package, and they'll facilitate supply of further stop smoking medications for them. We're also in the next few months getting some funding to set up a tobacco dependent service in-house. So that will mean we'll have stop smoking advisors on site that will be able to go onto the wards or in outpatient clinics to provide patients with the support there, to kind of engage them and get them started. Service will be continued in the community. So we should hopefully have them in the next 6 months. Covered this. So the services they provide behavioural support to patients. So they're contacted weekly, and they'll discuss kind of any issues they're having with their medication or difficult trigger points and so on. So the advisors support them with that. They have access to a range of stop smoking medications. At the moment, there's limited face-to-face support. It's mostly remote at the moment, and it's all free. And they can self-refer themselves as well. So if they're not ready at the point of seeing you, they can be signposted to their local services and contact them when they feel ready. So in Nottingham City, there's a service called Stubbit that helps people in the community to stop smoking. Although our hospital referrals we have city care advisors that deal with hospital patients only. So the referrals go to them. And if anybody wants any of these cards for the local services, we can get them over to you. And in the county, we've got the integrated kind of lifestyle service. It's called Your Health, Your Way. So they cover smoking, alcohol, and weight management as well. And if there's anybody out of area as well, if they've been referred through Medway, it will still go to their relevant service as well. So if it's Derbyshire, Lincolnshire, Leicester, and so on. And just a quick slide on dealing with smokers on site, really. So as part of our smoke-free site policy, we do kind of say on there to only approach smokers if you feel safe and comfortable, to kind of remind them that it's a smoke-free site. So if you don't, then there's no obligation to do that. But the best way really is just to remind them politely that they need to be completely off the grounds if they want to smoke, but they are able to vape, and remind them that there is support available. So if it's a patient, they can ask on their ward, or if it's kind of a visitor, that they can ask their GP or local pharmacy for more information. And we also design these kind of contact cards. So they're available at the main entrances. So if you did want to approach someone but didn't want to talk to them, you can just hand out this card, really. So that gives the polite reminder, and then it's got the numbers at the back of them of the local services as well. And then here's just some information if there's any more kind of training requests or resources that you require, you can get in touch. So does anybody have any questions?